Hello everyone. My name is Ali Al-Khayyat and I'm an organizing member of Surgic Kuwait and I'm a surgical resident in the Kuwaiti board. Welcome to another session of Surgical Fix. Today's session will be on adrenal incidentaloma. And just before we start, I would like to remind everyone about our current series that are ongoing with Surgic Kuwait, such as the ABCs of research with Dr. Sarah Lyoha on how to write a paper for publishing, and our surgical debate series. And of course, our weekly session of Surgical Fix that will be ongoing every Sunday. So without further ado, I would like to introduce our guest speaker from USA Today, Dr. Raymond Grogan. He's the section chief of endocrine surgery at Baylor St. Luke Medical Center. And he completed his residency at general surgery residency at Stanford University, followed by endocrine fellowship at the University of California. Welcome, Dr. Raymond. It's a pleasure to have you with us today.
Thank you very much. It's a pleasure to be here. I appreciate the invitation to speak with everyone today. Sorry we couldn't be in person, but maybe in another year or so, that'll be back to the way it used to be. And thank you for that introduction. I'm Ray Grogan. I'm an endocrine surgeon, so basically all I do is thyroid, parathyroid, and adrenal surgery. And of course, today we're going to be talking about adrenal incidentalomas. So let's get started.
Just before we start, I'd like to remind everyone, if you have any questions, you can put them in the Q&A and we'll answer them towards the end of the session. Dr. Raymond, the floor is yours.
Great, thank you. So let's start out with just an overview of what the talk is going to be about today. We're going to start out with how we work up adrenal incidentalomas, talk about the details of all that. And then after we go through that, which is kind of the bulk of what we want to cover, but after we go through that, I'm going to show you some data to show you whether or not these guidelines that we use to work up incidentalomas actually work. And when we use these guidelines, what happens in the real world. Then we're going to talk a little bit about the surgical options available for doing an adrenalectomy. I'm going to give you a case presentation, which is kind of representative of why we have to work up incidentalomas to begin with. So let's get started with the basics. So what exactly is an adrenal incidentaloma? So essentially, the easiest way to think about it is these are nodules on the adrenal gland that were found when we weren't looking for one. So if we have someone, for example, who has hypertension on multiple medications and we're concerned for an aldosteronoma and we do a CT and find something, that's not an adrenal incidentaloma. But if we have someone with right upper quadrant pain who's presenting as possible gallbladder problems and they end up getting a CT and find a nodule on the adrenal gland, that would be considered an incidentaloma. They're really common. About 10% of all CT scans that are done have an adrenal incidentaloma found on that CT scan. You can probably extrapolate that out to mean that about 10% of the population probably has an adrenal incidentaloma. That 10% rule is kind of constant. I mean, you find 10% of the population has a papillary thyroid cancer, 10% of the population probably has a breast cancer that they weren't aware of, 10% of the population have these adrenal incidentalomas. They're just very common, as are other things that are found incidentally. So that's kind of like, the funny thing is the term incidentaloma was described originally when we were talking about adrenal nodules. So prior to adrenal incidentaloma being named, the term incidentaloma didn't really even exist. So now we have thyroid incidentalomas, breast incidentalomas, etc. But the original incidentaloma is the adrenal incidentaloma. So when we talk about incidentalomas of the adrenal gland, obviously we want to know exactly what they are when we find them. And I like to try to keep things as simple as possible. And so this is where we start to talk about how we get into working these things up and thinking about them. So when you find an incidentaloma, just remember there are 7 things that an incidentaloma can be. And if you remember these 7 things and remember what those 7 things are and how to work them up, then you pretty much know exactly what to do with any incidentalloma. And of course, we're going to talk about all that in more detail now. So the 7 things, first of all, you have to break them into functioning and non-functioning. So the functioning tumors are obviously Cushing's, which is excess cortisol, pheochromocytoma, which are excess catecholamines, and an aldosteronoma, which is obviously excess aldosterone. So those are pretty simple to remember. And then you have this 4 non-functioning categories of things that these could be. Benign adenoma. This by far is the largest category. So the vast majority of adrenal incidentalomas are going to be just benign adenomas that are never going to cause anybody any problems at all. Adrenal cortical carcinoma. So this is a primary cancer of the adrenal gland. So a cancer that's arisen in the adrenal gland itself. They're pretty rare, but they are very aggressive. And so adrenal cortical carcinomas are one of the main things that we're concerned about when we're looking at these incidentalomas. Metastatic tumors. So it's not uncommon for other tumors to metastasize to the adrenal gland. Melanomas, in particular, lung cancers, and to a lesser degree, breast cancers are probably the 3 most common types of tumors that can metastasize to the adrenal gland. And then you have this 4th category in the non-functioning category that I just kind of have as an everything else or catch-all category, because there's a lot of really rare things that can show up in the adrenal that are all benign. They don't cause anyone any problems for the most part, but they're pretty unusual to find. And that includes myelolipomas, cysts, hemorrhagic adrenal gland, ganglioneuromas. And then, of course, you do have androgen-secreting tumors. Those usually show up in children, not so much in adults. If you have something that's secreting androgens in an adult, you have to be concerned, obviously, for adrenal cortical carcinoma. So again, that's kind of the first step. So when you think about an incidentoloma, remind yourself that there are 7 things it can be, and then you're going to start going down the pathway of figuring out what those 7 things are, or ruling out all 7 of those things. So let's get into the basics. How do we work these things up? So the first thing we do is imaging, and the second thing we do is biochemical workup. And that is really the essential steps associated with working up adrenal incidentalomas. Adrenal protocol imaging can be with a CT or an MRI, and a biochemical workup obviously is to rule out any of those 3 functioning tumors that we just spoke about. So when we first start with this, so we have our incidentoloma. Now we're going to talk a little bit about the imaging, or in general, just what the broad categories are in terms of the workup. So you find it, someone else finds it, they send it to your office. The first thing that's going to have happened is that you already had some form of imaging on this thing, because that's how they found it to begin with. So the first part of the imaging is the size. So you have things that are less than 4 centimeters and things that are greater than 4 centimeters. We'll talk about this in more detail, but essentially, if you're greater than 4 centimeters, it's coming out no matter what. If it's less than 4 centimeters, then we have to kind of figure out what exactly is going on with it. And so if it's less than 4 centimeters and has benign imaging, we do go on to functional testing. If it's functioning, we take it out. If it's not functioning and it's under 4 centimeters and it looks benign, then we just observe it. And on the other side, if you're greater than 4 centimeters, or if it looks suspicious in other ways on the imaging, we still have to do functional testing because we want to make sure there's no pheochromocytoma in particular. But regardless, we're going to end with an adrenalectomy if it's either over 4 centimeters or it's got suspicious imaging characteristics. So that's just kind of the broad strokes. And if we find out that if we go down this pathway of observation and non-functioning, then what are we going to do? We're going to repeat all that stuff in 6 months, and then we're going to do it yearly for 3 to 5 years. And really what we're doing with the imaging, if it looks benign initially, is making sure that it's not growing by more than 1 centimeter per year. And if it's not growing by more than 1 centimeter per year, we continue to repeat that imaging for a minimum of 3 years. If after 3 years it's still not growing, we can just kind of forget about the imaging component of it. And then we're going to do functional testing. All the biochemical testing gets repeated every year for somewhere between 3 and 5 years. It's a little bit controversial as to how long you need to do that for. The safest route is 5 years. This is because these things can become functional over time, particularly cortisol secreting tumors are the main ones that can become functional when they're not initially functional. But we do that for, let's say, 5 years. And if after 3 and 5 years, there's no functionality and it's not growing, then you can forget about it. The patient can forget about it and you never have to do anything to it again. And then, of course, if any of these things is not true, if it is growing by more than 1 centimeter or if it becomes functional, then they proceed again to adrenalectomy. So that's kind of the broad strokes of what we do here. And now we're going to get into the fine kind of minute details of actually how that works, and all of the details of how we do that entire workup. But that again was the broad strokes. Imaging, biochemistry, depending on what it all looks like, adrenalectomy, no adrenalectomy. If no adrenalectomy, follow up for 3 to 5 years. So let's start out with the adrenal protocol imaging. So why do we do the imaging and why do we repeat the imaging? Of course, we just talked a little bit about growth, but the other thing we talked about was, does it look suspicious on imaging? And so this is really kind of the nitty-gritty details of why we're doing this imaging. It's because essentially with the imaging, we're trying to rule out is adrenal cortical carcinoma or metastases for that matter. But in reality, we're making sure it's benign and not a cancer. And the way that we do that with the imaging is to look at the lipid content of the tumor. So how much fat is in the tumor and how much vascularity is in the tumor. So if it's got a lot of fat and no vascularity, it's benign. And the reverse is also true. If there's very limited fat, but with a lot of vascularity, we're very concerned for it being a cancer or a pheochromocytoma. And how do we look at fat content and vascular content on imaging studies? There's a couple of different ways, but one of the main ways on the CT scan is with the Hounsfield's units. So fat has very low Hounsfield's units, and fat also washes out rapidly. If there's not a lot of vascularity pulling and holding the contrast in the tumor, it's going to wash out pretty quickly in the venous phase. And so this is the basics of why we do the Hounsfield's units. We do multiple time frames to look at the Hounsfield's units and to look at how much contrast is washing out over time with these adenomas. So you can have adenomas that don't have a lot of fat in them. They're called lipid poor adenomas. You may see this read out by a radiologist. And so they're going to have higher Hounsfield's units, but as long as they don't have a lot of vascularity, they will still wash out rapidly, and that still would be considered benign. And so the things that look worrisome or suspicious based on the Hounsfield units and the washout are pheochromocytomas, adrenal cortical carcinomas, and metastatic tumors. And so that's kind of why we're doing this and why we have adrenal protocol imaging. So this is the very specific imaging that you do for adrenal protocol. So it's a triphasic scan, essentially. So you do a scan that's pre-contrast. Then you do another scan right after you inject the contrast. And then you do a third scan about 15 minutes after injection of the contrast to allow that vasculature to wash out the contrast. So this is something that's changed relatively recently with this. So if it's a lipid-rich adenoma, on the non-contrast scan, if the Hounsfield's units are less than 10, according to the newer guidelines, you don't actually have to continue and do anything further. So once you have a Hounsfield units of less than 10, you essentially can call this benign, and then that's all you need to do. So you will find some radiologists now, when they get that pre-contrast image, if they look at it and they see that there's less than 10 Hounsfield units, they won't even do the injection phases anymore. That's, like I said, that's pretty new. So standard and traditional is to do the triphasic scan. So then you do the arterial phase, and what you're going to see is that the Hounsfield units are going to bump up into the 80 to 90 range. And then when the venous phase comes, you're going to see that that's going to wash out by 50%. So let's say, you know, your Hounsfield units went up to 90. What you want to see on the 15-minute delay is that it's dropped back down to at least 45. And that's going to give you the washout of at least 50% on the venous phase. If you see that, then that means it's benign. So the lipid poor adenomas are going to have the Hounsfield units of greater than 10 on your non-contrast, which is going to be a little more worrisome initially. Then you're going to do the arterial phase, and you should see the same thing occur. As long as you get that 50% washout, then you know that it's benign. Now, if none of that happens, so you have a non-contrast Hounsfield units greater than 10, and your arterial phase bumps up to over 100, or it doesn't have at least a 50% washout, now you're suspicious for those things we just spoke about, ACC, metastatic tumors, or pheochromocytoma. So that's really why adrenal protocol imaging is set up the way it is. This is it's pretty good at making sure that you don't miss anything. So it's pretty sensitive, but it's not very specific. So what that means is you're going to end up with this taking out a lot of nodules that you didn't actually need to take out. But the reason you're doing that is because you're sacrificing it for high sensitivity to make sure you don't miss adrenal cortical carcinoma, essentially. So MRI is also very good for this as well. And oftentimes what we'll do is, the initial scan is often a CT scan. It's usually not an adrenal protocol scan because obviously they weren't looking for an adrenal gland problem. And so you may find this, and then you get sent this patient, 3 weeks later into your clinic. So now you don't really want to repeat another CT scan 3 weeks later because of the radiation exposure, et cetera. What we often do is then move to an MRI, and then the yearly follow-ups can be either CT or MRI as well. So with MRI, it's going to be a T1 and T2 weighted, and what you're looking for is the chemical shift imaging with gadolinium, and you're also looking for the washout characteristics as well on the MRI. I know myself as a surgeon, I'm much more comfortable reading CTs on my own than I am MRIs. I am much more dependent on the radiologist read when we have MRIs. But essentially what the radiologists are looking for is decreased signal intensity on the out-of-phase imaging, and also that same rapid contrast washout that we would see with the CT scan. And of course, as I said, oftentimes, at least for me, I often will just talk to the radiologist if I have any questions or concerns about it at all, as opposed to the CT, which I'm much more comfortable with. But both of them are very good. They're kind of interchangeable in this regard. One is not necessarily better than the other one, so they're both pretty reasonable imaging studies for this. So, we talked about how the broader scheme of how we do this. So first we got our imaging studies. Once we determine that it's benign on imaging, then we're going to go and do our biochemical testing. Now the biochemical testing, again, is to rule out those 3 tumor types. So the first one we're going to look at is pheochromocytoma. So obviously pheochromocytomas produce catecholamines, epinephrine, norepinephrine, and less commonly we have dopamine. So dopamine can be secreted by adrenal tumors, can also be secreted by paragangliomas. We can pause here for just a second and talk about the difference between pheochromocytomas and paragangliomas. They're essentially the same type of tumor. The only difference is that pheochromocytoma is basically a paraganglioma that arises in the adrenal gland. Paragangliomas can be all up and down the sympathetic chain of the body, so they can occur anywhere from the neck down through the thorax and into the abdomen, usually in the midline around the aorta and the vena cava, where the sympathetic chain is running. It can be around the carotids when it's in the neck. Neck paragangliomas oftentimes will be secreting dopamine more so than they will epinephrine or norepinephrine. And then the abdominal tumors will be more often secreting the epi and norepi and less often dopamine. We also find that with some particular genetic mutations, they're a higher risk of them secreting dopamine as well. But anyway, back to our adrenal incidentaloma. So the first thing obviously we want to do is rule out whether or not they're the tumor secreting metanephrines or catecholamines, because these are the most dangerous types of tumors that we operate on from an anesthesia perspective. So the best tests to rule out pheochromocytoma are the either serum or the urine metanephrines. So metanephrines are breakdown products of catecholamines. And so the reason that they are more sensitive is because the catecholamines, as you may be aware, aren't secreted at a basal rate. In other words, there can be spikes of catecholamines up and down throughout the day. There can be times when there's very low amounts of catecholamines being produced by the tumor. There can be times when the tumor spikes up and produces huge amounts of those catecholamines. But the catecholamines are broken down at a steady state. And so what this does is it causes metanephrines to be circulating in the system at a much more steady state than the catecholamines are. And so this allows for this test to be highly sensitive. And again, we're using a high sensitivity because we don't want to miss a pheochromocytoma. So on occasion, this test can be wrong. It can be a falsely positive test, but you'd rather have a false positive than a false negative when you're ruling out a pheochromocytoma, which can be a very dangerous tumor. And so you want to get the fractionated metanephrines. So that's norepinephrine. It's metanephrine, norepinephrine, which are the 2 main ones you're going to be able to find. And you can either do it in the serum or in the 24-hour urine. fractionated catecholamines are the second best way to do this to rule out pheochromocytoma. And again, that can be done either with serum or with urine, but is not quite as sensitive as the metanephrines are. Now, we oftentimes end up having to test both because the breakdown product for dopamine is a metanephrine called met-tyrosine. Met-tyrosine is not a common test. It's not something that we can commonly get here. And so oftentimes I have to order the metanephrines to rule out the epi and the norepi, but then we also have to go ahead and get a set of catecholamines to rule out the dopamine secretion. So that's something that's not quite clear in the guidelines because they don't go into this concept of what's the actual reality of day-to-day testing. But the truth is if you're looking at dopamine, you oftentimes can't even get the met-tyrosine data available, and so you have to end up ordering a set of catecholamines in addition to the metanephrines. So after pheochromocytoma, we're going to rule out Cushing's. So Cushing's disease, just to review quickly, is the pituitary releasing excess ACTH. That excess ACTH stimulates the production of cortisol from the adrenal gland. Cushing's syndrome is when the ACTH production is normal, but you have an adrenal tumor that's producing excess cortisol. So when you talk about adrenal incidentalomas, what you're talking about is Cushing's syndrome and not Cushing's disease. So in order to screen for Cushing's, obviously what we're screening for is an excess production of cortisol. So the first and most important thing to know about this is that you cannot take random urine or random serum levels of cortisol. Remember, cortisol has a diurnal variation, so it's being secreted at various times with different levels in the body depending on the time of day. So this has a lot to do with the circadian rhythm of the body, and the cortisol's production is part of that circadian rhythm. So if you order just a single spot urine or serum, you're going to get an invalid test essentially when you're trying to rule in or rule out Cushing's. So there are multiple ways of doing this, which we'll talk about. But if your suspicion for Cushing's is low, in other words, they don't have the round moon facies, they don't have a buffalo hump, they don't have purple striae on their abdomen, they don't have easy bruising. If they don't have any of those signs or symptoms, then you have a low suspicion and you can get by with just one of these tests. If your suspicion clinically is high, and one of these tests comes back negative, you want to repeat that test or even go to a different type of test to make sure that you haven't missed Cushing's. Cushing's, particularly in its beginning stages, when it's not producing huge amounts of cortisol, can be somewhat difficult to diagnose biochemically. And so you may end up having to get an endocrinologist to help out with this. But the initial step here is pretty straightforward. So the first thing that you can do is a late night salivary cortisol test. So pretty simple. The patient just has to essentially spit into a test tube around midnight. They bring that back to the lab, and the lab can test that for cortisol level in the sputum. You can do a 24-hour urinary cortisol. As long as the patient collects the 24-hour urine appropriately, this is a very good test. And then the one that's probably the most accurate of these three is the 1 milligram overnight dexamethasone suppression test. So dexamethasone essentially is going to suppress the ACTH production. That suppressed ACTH in a normal person then will suppress the amount of cortisol that's being produced by the adrenal gland. And so what you do is you give them a 1 milligram dose of dexamethasone around midnight. Then the following morning, around 8 a.m., you have them draw labs and you look at the plasma cortisol levels. And in a normal person, the plasma cortisol at that point should be suppressed to below 1.8. If that suppresses, then what you know is the adrenal gland is not producing excess amounts of cortisol. If it doesn't suppress, then you have to have concern that the adrenal gland is producing too much cortisol and you have Cushing's syndrome. Similarly, obviously, if the late night salivary cortisol is elevated or the 24-hour urinary cortisol is elevated, then essentially that adrenal tumor is producing too much cortisol. So the third functional tumor that we're talking about here is aldosteronoma. So interestingly, aldosteronomas are actually much more common than people realize. It's estimated that about 10% of all hypertensive patients actually have an aldosteronoma. In the United States, I believe there's about 50 to 70 million people with hypertension. That's more than a third of the population or so. And so you can see that you could extrapolate there that there are about 7 million people in the U.S. with an aldosteronoma. That may sound a little high, but those are statistically what the data show. So aldosteronoma is essentially a surgically curable form of hypertension. And so, there are a lot of sequelae to hypertension, obviously, with a lot of downstream effects. There's been a lot of arguments as to whether it makes sense to screen the population, at least the hypertensive population, for aldosteronomas. Some European countries are better at that than the US. The US currently does not recommend screening for aldosteronomas, although there's a lot of data accumulating that maybe we should be. Obviously, the aldosteronoma itself, the excess aldosterone, leads to chronic hypertension. But the exposure to the aldosterone alone causes an associated stiffening of vessels, and it in itself increases the risk of CVA and coronary artery disease. So it's important to treat aldosteronomas when they're found. So this also isn't as straightforward as you might initially think. It's not accurate to just check an aldosterone level. What you really need to check is the ratio of aldosterone to renin, the aldo to renin ratio, essentially. So you're going to draw both of these labs. If a plasma aldosterone is greater than 15, you have a suspicion for aldosteronoma, but that's not diagnostic. Because what's going to happen is the high aldosterone is going to suppress your renin activity. And it's the combination of the aldosterone with the suppression of renin that's going to give you the diagnosis. And so what you want to see is the aldosterone to renin ratio being greater than 20, and that makes you diagnostic for aldosteronoma. So essentially what you're going to see is an aldosterone of, let's say, 20 with a renin of, let's say, 0.1, or even 1 for that matter. But anything under 1 with an aldosterone of 20, and it's going to be diagnostic for an aldosteronoma. If this is also confusing, which it can be in certain cases, my recommendation would be to get an endocrinologist involved, but you can also do a salt suppression test to confirm it. And so what you do is you load them with salt. You give them a high salt diet, essentially, and that salt should suppress the aldosterone levels in a normal person. If it does not suppress, then you know also that you're concerned for an aldosteronoma. So that's kind of the summary of the adrenal protocol imaging, as well as the biochemical testing and workup. So it sounds complicated, but when you take a step back and take a bigger view of it, it's actually quite simple. You do a CT scan adrenal protocol, you test for those 3 functional tumors, and in doing so, you've essentially been able to identify, or should be able to identify, if this thing is any of those 7 tumors that we first spoke about. And so just remember, to make it even more simple, going back to our broad overview of the concept, this is really what you're looking at here. If it's greater than 4 centimeters, if this imaging looks suspicious, or if it's functioning, then it comes out. If it's not doing any of these things, then we continue to follow it for 3 to 5 years, as we talked about in the beginning. These guidelines are from ACE and American Association of Endocrine Surgeons back in 2009. The urologists also have a set of guidelines. The radiologists have a set of guidelines. They do vary to some degree. They're more or less the same, but in general, these are the guidelines that, as an endocrine surgeon, we would focus on, and are, in my opinion, the best set of guidelines to focus on. And so all that workup I just spoke about is essentially comes from those sets of guidelines that they're obviously much more involved than that. There's a lot of good information in those guidelines in terms of the background of why the tests work, why they don't work, when they fail, why they fail. But what I just gave you is a succinct breakdown of exactly what those guidelines are telling you to do in order to work up an incidentalloma. So what happens when we follow these guidelines? Do they work? And if they work, what exactly are they doing? And so we looked at this quite a while ago now. This is a surgical series of around 500 adrenalectomies that were, and 81 of those 500 adrenalectomies were incidentalomas, essentially. It was a series done over 15 years at UCSF. So what did we find? So when you follow these guidelines and the person ends up going for surgery, this is what happens. So 40% of all the incidentalomas are just going to be benign adenomas that no one really had to even think about. And all of this is unnecessary surgery. It's unnecessary in the sense that the patient could have lived with it for the rest of their life and never have to do anything about it. It's necessary only in the sense that we have no better technology to figure out when something's benign adenoma and when it's not, other than what these guidelines tell us. About a third of these incidentalomas will be functional tumors, and in about 15% of them will be non-functioning non-adenomas. So this is things like cysts, myelolipomas, and things of that nature. Then you got a small number of these which will be the cortical carcinomas, and even smaller number which will be metastatic tumors. This is probably not as representative as it should be to how many tumors do metastasize to the adrenal, only because oftentimes they don't get operated on if they have metastases to other parts of the body. We do operate on metastatic tumors to the adrenal if it's the only site of metastases. So let's say there's a lung cancer, the lung cancer has been treated, and then the patient shows up with an adrenal tumor that we are concerned to be metastatic for lung cancer. If there's no other metastases anywhere in the body, then it is reasonable to remove that adrenal gland. Some data suggest that there's a higher survival rate when that metastases is removed. Obviously, those data are hard to interpret because it's relatively rare still, so there's not huge numbers on this, but you can in fact go ahead and remove that adrenal in those cases. So what about the functional testing accuracy? So that was just overall what you find when you remove incidentalomas. But how accurate are the functional tests? So here's the 81 incidentalomas that were identified. Remember, 37% of these turned out to be functioning. So we had in this series, 35 of them were either functioning or were borderline functioning, meaning that the biochemistries were suspicious but not completely diagnostic for a functional tumor. And 46 of them were completely non-functioning based on those tests that we were just talking about. And when you look at these functioning or borderline, you had 6 aldosteronomas, 8 of them were subclinical Cushings, 12 of them were pheochromocytomas, and you had 9 of them that were borderline pheochromocytomas. So when we try to diagnose a pheochromocytoma, what we want to see is that the metanephrines or catecholamines are at least 2 times the upper limit of normal. Some people say it's 3 times or 4 times the upper limit of normal to make the diagnosis. But a minimum, so let's just say, for example, that your testing cutoff is 100, just as a round number. If you come back with a catecholamine that's 150, that would not be diagnostic for a pheochromocytoma. And again, remember, we take a lot of false positives with this test in order to not miss pheochromocytoma. Now, if it went to 200 or 300, then that would be diagnostic. So borderline means it's less than 2 times the upper limit of normal, but it is mildly elevated. So elevations in catecholamines can be due to the incorrect testing environment, stress during the testing environment, certain blood pressure medications, certain antipsychotics can all mildly increase these numbers and cause false elevations. So the 6 aldos were aldos, the 8 subclinical Cushings were subclinical Cushings. And then it turned out that 3 of these borderline theos were actually pheochromocytomas. This is an important piece of information. 4 of these borderline pheochromocytomas were just benign adenomas, and another 2 of them were non-functioning non-adenomas, so myelolipomas or cysts or other things of that nature. And in the non-functioning group, you had 4 of them that were less, you had 23 of them that were less than 4 centimeters in size, 17 that were 4 to 6, and 5 that were greater than 6. And of those, 1 of them was actually a pheochromocytoma, even though it was completely non-functioning based on the biochemistries. This happened to be a very small tumor. It was less than 2 centimeters in size, which is likely why the biochemistries didn't really pick it up. And clinically, it was probably not a functional pheochromocytoma. As it grew over time, it probably would have become a functional pheochromocytoma, but on histopathology, it was identified as a pheo. The vast majority of these non-functioning tumors were just benign adenomas. You had a handful that were non-functioning, and then you had 3 of them that were cortical cancers, essentially, or primary tumors of the adrenal gland. So that's really what you can see. So in the vast majority of cases, your workup is pretty accurate. You got some question marks with some of those borderline theos, but in general, everything looks pretty good. And there was one metastatic tumor that ended up having a biopsy. We don't necessarily recommend biopsying metastatic tumors because if it looks suspicious on the imaging, it should come out anyway. So there's no need to really biopsy it. And of course, if it's a theo and you biopsy it, you could incite pheochromocytoma crisis. So we actually don't ever recommend biopsying adrenal tumors. Obviously, these things happen before it gets to your office, though, which was the case in this particular series, and it was identified as a metastatic tumor. So this is kind of a list of exactly what all those tumors look like. So again, 42% of them, just benign adenomas, never actually had to be operated on, but due to either size or characteristics, they came out. 20% of these were theos, 10% were subclinical cushings, 7% aldos, simple cysts, cortical carcinomas, pseudocysts. These are the whole list of things that it can be other things other than the other 6. And then we had one metastatic tumor here. So interestingly, with the subclinical cushings, this is why, the main reason why we continue to do the biochemistries for 5 years after the initial diagnosis, because this can sometimes show up in myelolipomas, for example. We estimated that about 10% of myelolipomas at some point will produce some certain amount of cortisol. And so this is why, if you don't find it initially, over the years, as these tumors grow, they can become functional in that regard, which is why you have to continue to test these people for at least 3 to 5 years. And so this comes back to the concept of size. So why is that 4 centimeter cutoff what we use to determine whether or not we have to operate on something? So remember, regardless of functionality, regardless of what it looks like on imaging in terms of suspicion or not suspicion with Hounsfield units and washout, if it's over 4 centimeters in size, we recommend removal. The reason being, you can see the cortical carcinomas here. 2 out of the 3 were obviously over 4 centimeters in size, and the third one was borderline nearly 4 centimeters in size and would have progressed to be 4 centimeters in size in not too long. And you can see that the amount of other things that can grow to be large are pretty small. So the vast majority of benign tumors are going to be small, and there's a handful of them that are going to be large. So as you go up, the percentage risk that something is a cortical carcinoma gets higher, the higher the size of the tumor goes. These things turn out to be cysts usually, these really big things, occasionally a myelolipoma, but oftentimes simple cysts can get to be quite large and need to be removed. So this essentially, and this is this one single set of data, but these data have been shown over and over again to correlate. So we do know that size does correlate with some degree to cortical carcinomas, which is why we recommend removal after 4 centimeters in size. The guidelines say that the need to remove is between 4 and 6 centimeters because the majority of them are actually going to be over 6 centimeters. But because you do catch them in that 4 centimeter range, guidelines say somewhere between 4 and 6. If you want to be safe with these things and not miss an adrenal cortical carcinoma, we basically make the cutoff at 4 centimeters. So what is a summary of all the data on whether or not those guidelines work? Essentially, these guidelines reduce the number of benign adenomas being resected by 50%. So what we didn't talk about was the flip of that. So 50% of the tumors would have been removed without the guidelines just because we wouldn't have known what they were. Preoperative functional testing is very accurate with the exception of borderline theos. Now, because these borderline theos can sometimes be actual pheochromocytomas, we do recommend that they be alpha blocked prior to surgery for these things. Even if we don't make the diagnosis of pheochromocytoma, if there are borderline elevations, you're safer than not to go ahead and alpha block them anyway, just because a certain number of them will be pheochromocytomas. So that's essentially how we work these things up and what we do to take care of them. Obviously, surgery is kind of the end point here for anything that looks worrisome or suspicious at all. So what are our surgical options? So we can do laparoscopic transabdominal, we can do laparoscopic retroperitoneal, and then we can do open. So open operations, essentially laparoscopic surgery has become the gold standard for adrenalectomy in most cases. Open is reserved for something that's extremely large. So the cutoff there is around 10 centimeters. Anything under 10 centimeters can be done pretty routinely laparoscopically if you do a lot of them. Anything over around 10 centimeters is going to be difficult to get out, but can be done in some cases, especially cysts. So did, for example, a 12 centimeter cyst a couple of weeks ago. You can actually just aspirate that cyst content and then get that tumor out that way laparoscopically. And of course, adrenal cortical carcinomas, it's somewhat controversial as to whether or not you should operate laparoscopically on any adrenal cortical carcinoma. So anything that's small, the data suggests that if it's a high volume surgeon doing it, it can be done safely. If it's a low volume surgeon, the best option is to just, if there's any suspicion at all for adrenal cortical carcinoma, the best option is just to go open. The reason for this is because R0 resections and ACCs have been shown to improve survival. So if you do not get an R0 resection on an ACC, meaning you don't get all the tumor out at the initial operation, it's essentially as if you never operated on the patient to begin with, other than for symptomatic causes, symptomatic reasons. So it's very important to get a full, complete resection of ACCs at the initial operation, which is why a lot of people suggest just going straight to open if there's a high suspicion for an ACC to begin with. The laparoscopic, as we said, for the majority of these things is the gold standard. Transabdominal is probably the most common approach. Retroperitoneal is becoming more common. Some of the advantages to a retroperitoneal approach are that it can be done for bilateral adrenalectomy. Anyone who's had previous abdominal surgery, it's probably going to be easier to go retroperitoneal to circumvent the scar tissue from the transabdominal operation that was done previously. The retroperitoneal can be difficult in obese patients. So we have obviously a fair number of obese patients that we operate on. And in obese patients, it's probably going to be easier to go transabdominal. For people who do retroperitoneal approach, once they have a high volume of this, it's actually a faster operation in many cases than the transabdominal. The recovery time is actually probably even better for retroperitoneal. So there are reasons to consider learning and doing the retroperitoneal approach as opposed to the transabdominal. And of course, the reason laparoscopic surgery is now the gold standard is because it does reduce the length of hospital stay, it does reduce postoperative pain, it does reduce the risk of hernia, and it does reduce the amount of infection to some degree. So there are clinical reasons why laparoscopic adrenalectomy is now the gold standard in most cases. So when we're talking about surgery, it's important to review the anatomy. So of course, the adrenals are sitting at the upper pole of the kidney on each side. On the left side, the adrenal vein is going to be emptying down. So here's your phrenic vein, and the adrenal vein is going to be emptying down into the renal vein. Just keep that in mind. So the left-sided adrenal vein is going to be long, and there's going to be a fair amount of space here to be able to clip or ligate that adrenal vein. The phrenic vein is pretty commonly found, and you can often find it sitting up against the adrenal gland here. And if you trace it down, it will come and join the adrenal vein and can help you find the adrenal vein in difficult cases. The adrenal arteries are not really consequential in terms of having to isolate them in order to remove the tumor. They're very small and usually are taken with either a hook monopolar cautery or with a ligature device. This is not to scale. The right adrenal gland obviously is still sitting here. It's underneath the liver. The adrenal gland is actually sitting right up against the vena cava. This is pulled apart just for illustrative purposes, but this is essentially up on the vena cava. This adrenal vein is extremely short, oftentimes so short that it's even hard to get a clip on it, which is what makes the right adrenal gland surgery a little more complex than the left. Interestingly enough, it's actually the right adrenal surgery is actually faster than the left adrenal surgery in general, but it is also more dangerous because if you have bleeding here, you essentially have a hole straight out of the vena cava in a laparoscopic procedure if you lose control of the adrenal vein. These tumors can often be sitting down on the renal hilum as well, so you have to take care not to injure the the renal vessels, particularly if these tumors are large, they can displace down into the renal hilum as well. So again, the paragangliomas sit along the aorta here on either side. If they're on this side, they oftentimes are sitting between the vena cava and the aorta. These little arteries tend to be perforating right into the aorta oftentimes when they're paragangliomas, and it can be quite stuck and inflamed. You can find them anywhere along this axis. So just kind of a side note there. This is the setup for a transabdominal adrenalectomy. It's done laparoscopically. It's usually 4 ports. You can do it with 3 ports in some situations. 4 ports just makes it easier, makes the surgery go a little bit faster. You can use a combination of 5 and 10 millimeter ports, depending on what kind of instrumentation you're using. It's essentially right up under the rib cage, from the xiphoid down back to the iliac crest, more or less. So this is what that setup actually looks like in real life. And again, those ports are going to come right along here. You can see the bed is broken. This allows this space between the ribs and the iliac crest to open up and give you more access to that space here. Here's what those ports look like. Here you have a 5 millimeter port, another 5 millimeter port, and 2 10/12 millimeter ports here. Camera and working instrument can move in and out and interchange in between these 2 ports, which is why I use 2 10s here. You don't have to use 2 10s. You could use 3 5s and 1 10. You could probably get by with all 5s as well if you really wanted to. But realistically, there's not a whole lot of clinical reason to do all 5s in this particular case. So looks like we're coming up on an hour now. So let's do our case and then we'll be finished and have some time for discussion. So this is a 55-year-old woman, no significant past medical history that's interesting for us. She's had a hysterectomy and knee surgery. She had a brother with renal cell carcinoma and someone with thyroid cancer in the family, but that person had had radiation when they were younger, not really taking any medications of consequence. So she had mid-epigastric pain. Then she said she might have had some hot flashes and sweating and a little bit of anxiety, which was due to menopause. But obviously these are a little bit of red herrings here or warning signs. She didn't have any headaches or paroxysmal hypertension in her history. She'd had a 30-pound weight loss, but she thought that was intentional. She was actually trying to lose weight and exercising and dieting, etc. But what happened was she had epigastric pain, which eventually led her to get a CT scan of her abdomen, which found that she had gallstone disease and had her gallbladder out, I believe. But when they worked her up for epigastric pain, they found a 1.6 centimeter left adrenal incidentaloma. So first thing we know already, it's very small. So it's way under that 4 centimeter cutoff, so we don't have to worry about size. Here's the CT of the abdomen. You can see here, this is the kidney here, and here's the spleen here. And that tumor, I don't know if we have cuts of this. We don't have cuts of it. But the tumor is sitting over in here somewhere. This is the end of the, I don't know why we don't have these cuts. Sorry about that. Usually I don't have it so you can actually see it. But on this side, you can see that adrenal vein coming down here. And you can see the tumor sitting right here. And there's that adrenal vein. And you can see the adrenal vein actually on this image right here, which is going to come on further down. So the CT scan had pre-contrast Hounsfield units of 30. So it's not under 10. So we can't just stop here. So when she got the contrast, she had Hounsfield units of 50. Not terribly concerning, but we did not have a washout phase because this scan was not done for an adrenal gland. So this was not really helpful for us. So we had to repeat. So this is an important piece of information here. So you might say, oh, its CT is 1.6 centimeters. It's small. The Hounsfield units didn't get up over 100. So we're not really worried about anything here. We don't have the washout phase. Who cares? Well, the washout phase is very important. This is why it's part of the protocol. So we had to repeat everything because the initial scan didn't have what we needed. So we did an MRI just like we were talking about. The MRI measured it at about 1.9 centimeters, not really a significant difference between the two types of imaging studies. But the problem was there was no signal dropout on the opposed phase, which is one of the characteristics that we want to see on an MRI in order to make it completely benign. So at this point, you have this tiny little tumor that probably is inconsequential, but we have some weird looking MRI characteristics. So she goes to the OR based on those protocols. We also did our functional testing, which showed basically that it was non-functioning. So aldosterone, renin, the ratio here is not elevated. It's only at 6.7. Her cortisol was 6.9. This was a midnight salivary cortisol, I believe. And then we have her metanephrines, which is the fractionated metanephrines, and so metanephrine and normetanephrine, also both of them not elevated. So we have no functioning tumor here. All we have is this unusual washout characteristic, essentially. So we did a laparoscopic left adrenalectomy. We found a well-encapsulated tumor in the superior pole of the gland. We didn't find any evidence of any invasion or anything like that. It just looked like a routine adrenalectomy, essentially. And she went home post-op day number 1. We have actually started sending some of these people home post-op day 0 now, but she basically stayed overnight in the hospital and went home. So what's interestingly, the final pathology, so between the time that we had imaged her, gotten her worked up, got her to the OR, and the time that she actually got into the operating room, this thing had grown from 1.6, 1.8 centimeters all the way up to 2.5 centimeters. And it was called a myxoid adrenal cortical tumor, which basically is a adrenal cortical carcinoma, but a very small one, essentially. And she had a Weiss score of 3, which was a high nuclear grade with capsular invasion, less than 25% clear cells. Essentially, it was adrenal cortical carcinoma that was caught because of the washout characteristics. We followed her for, I think, 5 years with repeat imaging. She never had any signs of recurrence. I think at some point we may have stopped imaging on her after that. But this is a clear example of why, even though everything looks great, like there's no problem, you just have to follow those guidelines, because you can, in some cases, pick up something that could be devastating if it's missed. I mean, if this thing had continued to grow, these are, like I said, highly aggressive tumors. They will metastasize. They will cause death. The survival rates are pretty low when adrenal cortical carcinomas get to be too big. This is just this particular type of tumor is pretty rare, this myxoid adrenocortical variant. There's only been about 30 of them reported in the literature. This happens to be the smallest one ever reported. The smallest one prior was 5 centimeters. I don't think we ever wrote this up. And this particular type of tumor is even more aggressive than the typical adrenocortical carcinomas. So this person, if we had not caught this and done this operation for her, probably would have not done well. So that's the end of the talk. I'm happy to take any questions at this point. You can always email me. I do have Twitter. You can follow us on Twitter. And if you have any questions at all at any point about any of your patients or anything, I'm always happy to talk in more detail about these things. So thanks again for listening, and let's have some questions.
So, so far, we had pretty straightforward questions that been answered in the Q&A. Other than that, we're just gonna wait a moment, see if anyone else has any questions for you. As we just mentioned, if anyone has any questions, please put them in the Q&A and we'll be happy to take them on.
All right, I might have a question, Dr. Grogan, Salman here. Question about selective venous sampling, and what are the chance of somebody with aldosteronoma to come off medication after surgery?
Yes, great questions. So if you diagnose an aldosteronoma, depending on the patient's age, you will need to do adrenal vein sampling. And the reason for that is because aldosterenomas can sometimes be bilateral, meaning that you have hyperplasia of both adrenal glands, as opposed to just a single adenoma in one adrenal gland. And CT scans and MRIs both are not great at determining adrenal hyperplasia. And so that's where selective venous sampling plays a role. It's much more accurate in determining whether you have one-sided or bilateral secretion of aldosterone. if you've got bilateral metaplasia, you don't want to take out both adrenal glands. You essentially give a person an even worse disease than they already have. And so that's why you do the selective venous sampling. It's very accurate. It's recommended in anyone over the age of about 40, and that's because incidentalomas and non-functional adrenal tumors increase with age. So if you find a tumor in someone who's, let's say, 20 years old and it's an aldosteronoma, the likelihood that they're going to have bilateral tumors is pretty low, and so you can pretty much skip the venous sampling. But if they're over the age of 40, there's a possibility that they have bilateral disease, essentially. In terms of whether or not they'll come off of their blood pressure medications, there's something called the aldosteronoma resolution score, which isn't perfect, but it's pretty good. And it takes several factors into consideration, including the patient's gender or sex, how many medications they're on, how long they've been on their medications, and what their BMI is. All these things play a role in whether or not they're going to come off of their hypertensive medications after taking out an aldosteronoma. And that score will give you a score with a relative risk of being able to get off all of your medications or not. There was an international multi-institutional study done by a friend of ours from the Netherlands, who found that I think it was about 60 to 70% of people have good resolution after having an aldosteronoma removed, and about 30% of people or so are still going to be relatively hypertensive. And that's probably partly because the blood vessels change over time, and if you're exposed to the aldosterone and the hypertension for too long, those changes are irreversible. And so you have primary hypertension at that point, but it was probably caused by being exposed to aldosterone for many, many years, essentially.
Thank you for that answer, Dr. Raymond, and for that question, Dr. Salman Safran, our endocrine surgeon from Kuwait. Is there I think we have one more question from Dr. Abdulatif Ashkanani. When to suspect a metastatic adrenal tumor with occult primary, and a role of biopsy, when is it required? When it is required?
Yeah, it's a great question. It's one of the things that we kind of skip over oftentimes when we're talking about these guidelines. So, and we didn't actually talk about this. So let's say you go through your whole workup and you find that it's not 4 centimeters or greater. It doesn't look suspicious on imaging. It's not functioning. There is one more step there, and that is that they need to be screened for other types of tumors to make sure that it's not metastatic if it's at all suspicious looking or concerning. And so what that means essentially is the person needs to get their mammograms when that's appropriate. They should get a colonoscopy if it's appropriate. They should see a dermatologist to have their skin checked if it's appropriate. All those things are actually part of the guidelines for working these things up. So you do want to make sure that they get their full, regularly scheduled cancer screening protocols. Now, what that doesn't mean if you have a 20-year-old with an incidentalomas that you're going to do all that stuff to them. But what it does mean is that if they're 50, you've got to make sure they had their colonoscopy, you got to make sure they had their mammogram, et cetera. Remember, they just changed the colonoscopy guidelines at 45 now. Unfortunately for me, which I have not gotten mine done yet. I feel like an old man now. But anyway, you do want to make sure that if they're the appropriate age, they get all of their appropriate cancer workup to make sure that they don't have an occult metastases or a metastases from an occult tumor that was not previously diagnosed. We really try not to biopsy adrenal tumors no matter what. So there's really no reason to. Number one, adrenal biopsies are notoriously incorrect at diagnosing the tumor. And so that's the first problem. Now, if it's a metastases, it will probably be pretty accurate because you will see tissue that's not adrenal tissue in that nodule. But in general, the imaging studies are almost always going to pick up something that's metastatic because of the vascularity of metastases. So primary tumors are vascular, but metastatic tumors are even more vascular than primary tumors in general. They have to be in order to kind of seed and then grow. And so you will have very little problems in determining if it's a tumor or not based on the CT or the MRI. And if it's highly vascular and it meets that criteria for coming out, then it comes out. And so it doesn't matter if you biopsy or not, because it's got to come out anyway. If it's not highly vascular, the likelihood that it's going to be a met from some tumor you never found somewhere is extremely low. And so that's why it's not recommended to biopsy these things. Of course, if you go down the road of biopsy, it's extremely important that before you do that, that you rule out pheochromocytoma. Because you can, like we talked about, cause pheocrisis, if you are to biopsy a pheochromocytoma on accident.
Thank you for that extensive answer. And let's see if we have another question.
And Ray, if we have plenty of colorectal surgeons in Kuwait, if you decided to have your colonoscopy abroad, we can arrange one for you when you're here.
I'll keep that in mind. Thank you very much.
I guess that's it for the questions right now. Thank you, Dr. Raymond, for giving us your time to give us this lovely lecture. It's been a pleasure to have you with us on our platform, and we're looking forward to have you with us in future times. Let's remind everyone about our upcoming series. Our next week session for Surgical Fix will be on leak post-bariatric surgery, will be given by Dr. Saad Lithwani. And our ABC of research will be given by Dr. Sarah Rioja, which is about how to write a paper and how to publish it, and our surgical debate series. Of course, I want to remind everyone that our Surgical Fix series and our ABCs of research are both CME accredited by the American College of Surgeons, and you will receive your certificates by emails within this week. Once again, I want to thank Dr. Raymond Grogan and Dr. Salman Safran for his lovely questions, and we'll see you next week.
Thank you very much. I appreciate it. It's been great.
Thank you. I will leave the QR codes up for a few moments for anyone who would like to register using the QR codes, or you can use the links in the chat, in the Zoom chat. See you next week, everyone.